Welcome to Exercise Science 4160. This lecture is entitled The Tissue Response to Injury, and I've divided it into three different series. The first series, we're going to explore one of the most fundamental concepts in rehabilitation, and that's how the body responds to injury and heals itself. Understanding tissue response to injury isn't just academic knowledge. It's the foundation that will guide every treatment decision you make as a clinician. When you truly understand what's happening at the cellular level after an injury, you can design rehabilitation programs that work with the body's natural healing processes rather than against them. The first part of this series will focus on the different types of injuries you'll encounter in clinical practice. So let's get started. Before we dive in, let's look at what you should be able to do by the end of this lecture series. First, you'll understand basic terminology related to injury pathology. We'll be using terms like acute, chronic, degenerative frequently, and you need to know exactly what these mean. Second, you'll be able to identify the four phases of healing after an acute injury. This is critical. Hemostasis, inflammation, proliferation, and remodeling each have distinct characteristics and timeframes that directly impact your treatment choices. Third, you'll learn to differentiate between acute and chronic inflammation. These are not the same thing, and confusing them can lead to inappropriate treatment. Finally, and most importantly, you'll be able to apply this knowledge to guide your treatment plan. Theory is only valuable when you can translate it into clinical decision making. Let's start by understanding how injuries are classified based on their mechanism or how they occur. Acute injuries result from a single traumatic event, what we call macro trauma. Think of a football player getting tackled and spraining their ankle, or someone falling and fracturing their wrist. One event, one injury. Chronic injuries, on the other hand, develop over time from repetitive microtrauma. These are also called overuse injuries, like runner's knee, tennis elbow, swimmer's shoulder. By definition, we consider an injury chronic when it's been present for at least 6 months. These can be particularly challenging to treat because the tissue has undergone prolonged stress and adaptation. Finally, degenerative injuries are associated with aging and the natural wear and tear of the body's tissues. Osteoarthritis is a classic example. These aren't caused by a single event or even repetitive stress. They're the result of accumulated use over a lifetime. Understanding which category an injury falls into will immediately start shaping your rehabilitation approach. Now let's clarify two terms that students and even some clinicians frequently confuse: sprains and strains. A sprain is an injury to a ligament. Remember, ligaments connect bone to bone and provide joint stability. Sprains can occur from contact or non-contact mechanisms. Because ligaments stabilize joints, a significant sprain can lead to joint instability. And this has major implications for rehabilitation because we generally want to avoid any aggressive flexibility or other exercise early on that might further stress an already compromised ligament. A strain, conversely, is an injury to a musculotendinous unit, the muscle and its tendon. Since muscles are dynamic stabilizers and force producers, our rehabilitation focus shifts to joint stability exercises, strengthening, and dynamic balance training. Here's a simple memory trick. Think ST for strain equals tendon muscle, and SP for sprain equals ligament. Though I know it's a stretch, the key is understanding the functional implications of each injury type. So this image shows the grading system for sprains using the ankle as an example. Grade 1 sprain involves microscopic tearing of ligament fibers. The patient will have mild pain and swelling, but the joint remains stable. Most people can still bear weight. A grade 2 sprain represents a partial tear of the ligament. There's moderate pain and swelling, and some joint laxity may be present. Weight bearing is typically painful and difficult. A grade 3 sprain is a complete rupture of the ligament. This results in significant instability, substantial swelling, and often the inability to bear weight. Interestingly, grade 3 sprains sometimes present with less pain initially because the nerve fibers in the ligament have been completely torn. The grade of sprain directly influences your treatment timeline and approach. A grade 1 might return to activity in a short amount of time, while grade 3 could require several weeks or even months of rehabilitation or even possibly surgical intervention. Tendinopathy is a term you'll encounter frequently in clinical practice, particularly with active populations. First, let's remember anatomy. Tendons connect muscle to bone. They transmit the force generated by muscle contraction to move our skeletal system. Tendinopathy refers to the breakdown of collagen within a tendon, typically caused by repetitive loading that exceeds the tissue's ability to repair itself. This is classic overuse pathology. Common examples include Achilles tendinopathy in runners or patellar tendinopathy in jumping athletes, uh, lateral epicondylar tendinopathy called tennis elbow in racket sports. For rehabilitation, eccentric strengthening has strong evidence for promoting tendon healing and remodeling. We also utilize various modalities, including bracing for load management and, importantly, activity modification. The key is finding the right balance, enough stress to stimulate adaptation, but not so much that we perpetuate the breakdown cycle. Arthritis is a broad term that encompasses several conditions affecting the joint surfaces. Osteoarthritis involves degeneration of joints' articular cartilage. That's the smooth, protective cartilage covering on the ends of bones that allow for friction-free movement. It's more common in weight-bearing joints like the knees and hips because these experience greater compressive forces over a lifetime. Osteoarthritis is often called the wear and tear type arthritis. Another type of arthritis called rheumatoid arthritis is fundamentally different. Rheumatoid arthritis is a systemic autoimmune condition where the body's immune system attacks the articular cartilage in multiple joints throughout the body. Unlike osteoarthritis, which typically affects specific joints and oftentimes asymmetrically, rheumatoid arthritis often presents bilaterally, symmetrically, and can affect joints that don't bear significant weight. Both conditions significantly impact rehabilitation planning, but for different reasons. Osteoarthritis management focuses on joint protection, maintaining function, while rheumatoid arthritis treatment must also consider the systemic nature of the disease and potential medication side effects. So take a look at this radiograph showing an arthritic joint. What you're seeing is the loss of joint space that occurs as articular cartilage wears away. In a healthy joint, you'd see a clear space between the bones. That's the cartilage. Here, the bones are much closer together, and you may notice some irregularity at the joint surfaces. You might also observe osteophytes or spurs forming at the joint margins. These develop as the body attempts to stabilize the degenerating joint by increasing the surface area. As clinicians, we don't diagnose from imaging alone, but understanding what these changes look like helps you correlate your clinical findings with the underlying pathology. A patient with these radiographic changes will likely present with pain, stiffness, and reduced range of motion, and your rehabilitation program needs to account for these structural limitations. Spinal cord injuries represent some of the most life-altering conditions you'll encounter in rehabilitation. These injuries result from trauma or medical conditions that damage neural elements within the spinal canal. The result is impairment of motor and sensory function that is below the level of the injury. The location of the injury determines the extent of impairment. So injuries to the cervical spine, for example, can result in quadriplegia, affecting all four limbs and the trunk, while lumbar injuries may result in paraplegia, affecting the lower extremities and portions of the trunk. Here's a critical point. Spinal cord injuries do not regenerate. Unlike some other tissues we'll discuss, the central nervous system has very limited capacity for repair. This fundamentally shapes our rehabilitation goals. Rather than focusing on fixing the injury, we focus on maximizing function with the abilities that remain, returning patients to functional activities of daily living, and incorporating adaptive equipment such as wheelchairs. Some peripheral nerve injuries, those that are outside the spinal cord, may regenerate, but extremely slowly at approximately 1 millimeter per day. That's about an inch per month. So recovery can take many months to years. Traumatic brain injury, or TBI, is dysfunction of the central nervous system resulting from trauma or forces applied to the head that are significant enough to alter brain function. The impairments from a TBI can be broadly categorized into cognitive and physical domains. Cognitive impairments may include changes in mood, memory problems, impaired executive functioning, poor judgment, difficulty initiating tasks, attention deficits, and reduced problem-solving abilities. These invisible symptoms can be just as debilitating as physical impairments, sometimes even more so. Physical impairments commonly include altered gait patterns, balance deficits, and changes in sensation. Rehabilitation for a TBI is truly interdisciplinary. Speech therapy addresses communication and cognitive deficits. Occupational therapy focuses on activities of daily living. Physical therapy works on gait training, balance, and mobility. Neuropsychology may address cognitive rehabilitation. The key is coordinating all these services to help regain the maximum function for the patient. A stroke, also known as a cerebral vascular accident or CVA, occurs when blood flow to a part of the brain is interrupted, either by blockage or by a bleed. The resulting impairments depend on which area of the brain is affected, but commonly include altered strength, reduced mobility and coordination, paralysis of the face, arm, or leg, usually on one side of the body, visual disturbances, and changes in communication, judgment, and cognition. Rehabilitation after stroke focuses on regaining muscular strength and mobility, speech therapy for communication deficits, cognitive therapy, and extensive gait training. The brain has some capacity for neuroplasticity, the ability to reorganize and form new neural connections, which is why intensive, repetitive rehabilitation can lead to meaningful recovery, even after months from the initial injury. The time is critical with stroke. The phrase time is brain reflects the fact that rapid treatment can limit the extent of brain damage, and early rehabilitation can maximize recovery potential. Amputation or limb deficiency can be congenital, that is, present from birth, or acquired due to an injury or an illness. Diabetes is a leading cause of acquired lower extremity amputations due to the vascular and neurological complication that diabetes causes. The functional limitations depend significantly on several factors, whether the upper or lower extremity is affected, the level of the amputation, and whether it involves the dominant or non-dominant limb. Rehabilitation focuses on several key areas. First, we work on strengthening the unaffected extremities and the remaining portions of affected limbs. Second, we collaborate with prosthetists to fit the patient with appropriate orthotics or prostheses. Third, we retrain activities of daily living, which may require completely new movement strategies. For lower extremity amputees, the goal is often return to functional ambulation. For upper extremity amputees, the focus may be on fine motor tasks and ADLs. In both cases, the psychological adjustment is significant, and rehabilitation must address the whole person, not just the physical impairment. All right, class, this concludes part one of our lecture series. In part two, we'll dive deeper into the 4 phases of the healing process, the foundation for all of your treatment planning and decisions. And that part two series will begin with slide 13. Thank you very much.